So personal statement.
Personal statement's huge. If your personal statement starts as a basically text version of your CV, I'm immediately bored.
Yeah.
You got to hit me right away with something interesting about you. And I want it to be interesting. I don't want it to be, I saw a patient, they had a disease, it was the coolest operation I ever saw.
Yeah, you must read that.
This is why I want to be a
million
plastic
times.
surgeon.
Yeah.
I read that a lot.
Yeah.
That was yours, right?
Yeah.
I read that a lot. It's not exciting. It's not interesting. It doesn't mean it's not right. And if you have nothing else to write about, don't try to get crazy creative. That's a mistake.
Yeah. Okay, that's what I was going to ask. Anything to avoid.
Welcome to the DIEP End. Today, we're joined by Dr. Fosnot, Program Director at Penn Plastic Surgery, a surgeon educator who joined us for clear, candid guidance to applicants and trainees. After an early start in ophthalmology and a transitional year, Dr. Fosnot pivoted to general surgery, discovered microvascular reconstruction, and ultimately found a home in plastic surgery at Penn, a winding path that shapes his mentorship and leadership today. In this episode, we'll cover how to stand out in the application season, crafting a personal statement with a story, choosing letter writers who truly know you, smart strategy for away rotations, research years, and interview day. We also talk about what to do if you don't match, and nuanced takes on signaling and the integrated versus independent landscape. We also get practical on thriving as an intern and protecting yourself from burnout for a long, sustainable career. Let's dive in.
Welcome. Exciting day. This is overdue. We've been trying to do this for a while.
But also, it's time sensitive for what's going on right now. It's perfect timing.
You're right.
Yeah.
Which is?
Application season.
Yeah. Does it seem like just yesterday for you, probably?
It does. I still have nightmares about it.
It does not seem like just yesterday for me.
It's not a nightmare
just kidding.
though, right?
No,
I mean,
looking back, it's not. I feel like every step of the way, there's a new mountain or a new stress, but that's why you just have to learn to embrace the stress.
It's also an exciting time, I think, for students. They're one step closer to hopefully realizing their goals of becoming a plastic surgeon.
Yeah.
They're getting to see a lot of different programs, perhaps traveling to cities they've never been to, and sort of learning about how different health systems work. So I think it can be kind of an exciting time if you look at it the right way. You just you got to frame it the right way in your brain.
Yeah, definitely.
So before we get into that, you have a very interesting kind of background as to how you made it into plastic surgery. And it was one that kind of motivated me because I took a longer route. But I'm not going to take away the kind of the punchlines, but can you tell us a little bit about what got you into medicine, but also how you ended up in plastic surgery?
Sure. Yeah, we'll get to it, but I had a more convoluted route than most. And I definitely tell every student, don't do it this way if you don't have to. I mean, medicine in general, knew as a kid that I just liked being able to help somebody who's in need. I always enjoyed, never really quite a business-minded person. I just kind of liked a more one-on-one interaction. Mm-hmm. Loved science in college, and sort of a natural fit was sort of a medical field. So took a year off to do research. We'll finish my prerequisites and went to medical school. In medical school,
so you did a year of research even before medical school?
Correct. I did a year before, I don't know, maybe I'm just a slow planner, slow thinker, but in college, wasn't quite ready to go into medical school yet with prerequisites, so I had to make up for some of that in my senior year. So anyway, I did a year of research, went to medical school at Penn. During that time, I got very interested in not just the science of vision and sensory things, but I started doing some bench research in ophthalmology, which was incredibly exciting at the time. And I translated that excitement about the research I was doing into thinking I wanted to be an ophthalmologist. I thought it was a surgical subspecialty, meaning, I thought there was a lot of operating. And I knew I liked working with my hands. I applied in ophthalmology, I mastered in ophthalmology at Penn, and did a transitional year in preparation for that residency. And sort of somewhere in that transitional year, realized that I actually just really liked surgery. And I did another month of ophthalmology at the VA and realized that I didn't really like ophthalmology. And so I switched into general surgery. I had to repeat my intern year because transitional year didn't count as a regular internship. So I repeated my internship year. Liked a lot of things. liked vascular surgery, liked cardiac, but I realized that I also just liked putting things together more than taking them apart. And around that time, I met Joe Cerletti, who was here as the new chief, and pretty inspiring figure, and got me interested in microvascular surgery, and through that I learned more about plastic surgery.
Do you remember the first day you met? Like the very first time you met?
I definitely remember him being somebody who like dressed a little bit
Careful.
more to the T than some around here. Bright tie, probably a 3-piece suit. But more importantly, I just remember him, doing a free flap. I had never seen one before. I knew almost nothing about plastic surgery as a medical student, and I think unfortunately it's a specialty that some people just never really get any exposure to, and I had no exposure to it, so I didn't even really know what it was about. And in doing breast reconstruction in general surgery, I started to learn a little bit about it. I ended up deciding that that's what I wanted to do. That was right around the time that Penn was opening an independent training pathway. One of my best friends, who was also in my general surgery class, took the first year slot, and I needed something to do. Took a year of research after general surgery to be a research fellow here, and then I started in plastic surgery.
The first research fellow.
I was going to say.
Right?
I don't know. I thought Jonas Nelson was the first research fellow, but he was a medical student when he did it. I had already finished general surgery, and I was moonlighting as a general surgeon at the time. So our experiences were completely different. And then I stayed here for plastic surgery. I was fortunate that I didn't have to go through the matching process because they just took me from general surgery here.
I want to dissect it a little bit further because it's super interesting, and it takes a lot of courage, I think, to match into something that's a subspecialty, very competitive. You go through the whole matching process, and to have the self-awareness to say, I'm going to try for something else and change paths. I feel like a lot of people would say, I'm already this far into it. I'll learn to love it or something like that, or I like it enough. Like, what was your day-to-day emotions of? Was it a big deal in your head, or were you kind of just like?
It was a very big deal. I mean, I think making that decision is not easy at all. I think the unfortunate truth of the way that students choose what to do in their life in medicine is that you make potentially lifelong decisions based upon incredibly limited information. That is often based off of interactions that you have with certain people on a rotation where I don't know, I liked the case I was doing, and I liked the people I was interacting with, and that translates into you thinking that is going to be a good career for you. And that's how I got interested in ophthalmology. I met some people that I liked, did a couple cases, it seemed pretty cool, and I thought that would work. Could I have made that specialty work? I'll never know. Possibly. Probably would have finished training a lot faster. It's still a great specialty. I think people who like it, I still encourage them to do it. But I just knew that I didn't want to sit in front of a slit lamp. Seeing 50 patients a day for multiple days a week. That's what it seemed to translate into for me. But making that decision was very hard. I had to talk about that with my wife, talk about that with my extended family. I mean, it does have some long-lasting repercussions.
Yeah, for sure.
When you make changes like that, because if you prolong your training, you're delaying when you get your career started, which has problems associated with it, but you're also limiting your salary at the end of your career, right? You don't think about it all right, I'm just going to do one more year of residency training, it's only X number of dollars. You really need to think about it as the longer I'm delaying my career, those are productive years of your life at the end of your career that you're going to miss out on, because everyone generally has to retire at the same amount of time because of the finite human lifespan. So, they are important decisions. They're difficult, but think about it. A 25, 30-year career, you got to like what you do.
Sure.
And if you're very unhappy with what you're doing on a daily basis, it will translate into a lifetime of unhappiness. And you got to look at it that way.
Yeah, that's one of our prior guests said, if you love what you do, you'll never work a day in your life. So that's important. But now, fast forward.
I wouldn't agree with that.
It's still work. Some people say work is work, and then a lot of people say, if you love what you do, you never work a day in your life.
Who said that?
Sir Letty. Just kidding. I was trying to think of somebody you
That wouldn't surprise me.
But we did have a reoccurring theme that
No,
a
that's
lot
true.
of surgeons tend to work way past when people in other specialties would work. Like whether you're in business or something else, you usually retire earlier, whereas a lot of surgeons at least like it somewhat enough to work into their 70s, operate into their 70s.
I think there are a number of reasons for that. I think that surgeons start their career later. So, if you're in finance or whatever and you start your career in finance when you're 23 out of college, maybe you're bored with that earlier and you need to make a change. Maybe
That
as
makes
a
sense.
surgeon, you start later, you're still invigorated. There's financial aspects that go into that. You're playing catch up, whatever. I think the last component, which is probably real, is that a lot of surgeons actually enjoy what they do on most days of the week. I say most. The reason why I say I don't agree with it every day. I think no matter what you do,
Of
even
course.
if you choose the best specialty you could possibly choose, you're going to have days where it's difficult.
Yeah.
So fast forward to now. Now you're the program director. What is it? 7 years as program director?
Something like that.
So-
That's
yeah.
about right.
Did you ever see yourself in this role?
I did not see myself in this role. I think that, I enjoyed research in the couple of years that I did, but I knew that research wasn't really a huge passion of mine. But I have always known that I enjoy being around eager minds and people who want to learn, whatever. So to me, being in academic medicine was being around learners. And so whether I knew that would translate into being a program director, I have no idea. But, those things do go hand in hand, so it doesn't necessarily surprise me that I'm in this role at this point.
Yeah. So one of the things that we're interested in, particularly you being in this role and the fact that it's application seasons, is helping guide applicants, not just medical students, even trainees and things like that. So when you're taking an application or like even just offering medical students advice, what would you say are things like kind of the top things you tell them to increase their chances of a successful match? What advice do you give them?
I mean, the reality of plastic surgery is a very competitive match. And so some of it is completely out of your control, and you can't get too bogged down in that. I think the best things that you can do as an applicant is to highlight and tell a story. I think, I don't know, we probably review 300 plus applications per year. Some of them have no story. And I like reading a story. Everyone likes reading a story. Everyone likes knowing a little bit where you came from and what got you from point A to point B. It shouldn't read like a summary of your life. It should be a meaningful story that you tell that briefly explains something about you that may translate into why you're choosing to become a plastic surgeon. So to me, the most interesting applications are the ones that have a story that go along with that and demonstrate or highlight maybe some of the things they've done in their life that have contributed to that story.
So personal statement.
Personal statement's huge. If your personal statement starts as a basically text version of your CV, I'm immediately bored.
Yeah.
You got to hit me right away with something interesting about you. And I want it to be interesting. I don't want it to be, I saw a patient, they had a disease, it was the coolest operation I ever saw.
Yeah. You must
This
read
is
that
why I want to be a
million
plastic
times.
surgeon.
Yeah.
I read
That's
that a
Hank's
lot.
application.
That was yours, right? Yeah. I read that a lot. It's not exciting. It's not interesting. It doesn't mean it's not right. And if you have nothing else to write about, don't try to get crazy creative. That's a mistake. as
Yeah.
well.
Okay. That's what I was going to ask. Anything to avoid.
Yeah,
Too creative.
don't be too creative. You can help yourself a little bit with a personal statement. You can hurt yourself a lot with a personal
Yeah.
statement.
That's how I feel too.
Yeah, that's what I've heard is like it's a lot of red flags can come out because you're not in a standard format of the application. It's kind of a little bit more free. But I do also agree that it's not like other specialties where you do need to jump off the page a little bit because there's so few spots and so few interviews that it can't just be bland.
Yeah, it can't be bland. I think actually, one of the things that's become super important about a plastic surgery application is the letters of recommendation.
Yes. That was the next thing I want to talk to you about.
Most medical schools have gone to pass-fail. The USMLE is pass-fail. Everyone does a lot of research. There aren't that many objective things that can separate you from other applicants. What certainly separates you from other applicants is having a number of very good letters of recommendation from people who know you well, not people who are well known.
Yeah.
Yeah, and how do you feel about, somebody rotating for a week or so and then getting a letter of recommendation? I mean, if they have to, I guess it's probably beneficial for applicants who come from medical schools who don't have plastic surgery programs. They might have to do that.
That was me.
But probably having a stronger letter from somebody who's known you for a long time, even if they're not plastic surgeons, would you say?
I think that's okay. I think, wouldn't necessarily get a letter from someone who's not even in medicine. I'm not sure that that's going to be translatable. But if you've worked in a lab with somebody not in plastics who knows you well, or you started in one specialty and transitioned to another, but that person knows you really well longitudinally, I think that's still a good person to get a letter of recommendation from. I think that one of the things that I really like to see, and not everyone can achieve, is having a great letter of recommendation from a couple of different institutions. It does highlight consistency in what you present to people. So if you go on an away rotation and you really feel like you hit it off with someone, get a letter of recommendation. Because if you've got two different institutions giving me the same message, that means a lot. That being said, if you don't think you did a great job in an away rotation and you don't know that person particularly well, I have seen applications be entirely tanked by one letter of recommendation.
Totally
it's very
agree.
clear that they rotated there, or they didn't impress them because they probably tried to get to know someone for a week and got a bad letter, and that's the death knell on your application.
Yeah, and I think that's why that's an important distinction between who knows you well and who's well known, because you might rotate at somewhere who has a big name and you work with them for a few days and you're like, if I can get a letter from him, it's going to make my application. But if he doesn't know you that well or you didn't impress him, that lukewarm letter is way worse than
Definitely.
a really glowing letter of recommendation from someone who knows you really well.
Yeah. And I think that, speaking anecdotally with some applicants, I think that they've noticed that too, like perhaps unmatched applicants like had a bad away rotation or bad experience, and then the letter showed that, and then that might be a contributing factor. But an interesting point actually for me, when I applied into general surgery, I had a private practice plastic surgeon write a letter, a pediatric neurosurgeon, and a general surgeon. So like completely different, but they were just people that knew me for a long time.
Yeah.
So,
and we have like all types of listeners.
Through the cracks and got in.
I really did. A private practice plastic surgeon for general surgery application.
It was a pseudonym you went under, right, when you were applying? No, I'm just kidding. Since we have a wide range of listeners, we have medical students, we have residents, we have attendings, we have people who aren't in plastic surgery, everything. So from the perspective of someone who might be writing a letter on somebody's behalf, what is something that you could do to write a glowing letter for somebody?
So, I mean, when I write my own letters, I start with some generics, about the applicant. I think that's a pretty standard way of opening a letter. But I definitely, in every letter, try to tell at least one anecdote that's very personal.
Yeah.
I think those translate into maybe getting to know an applicant a little bit better. If you polled our own faculty, it's not universal what any given individual looks for in an applicant. So take my words with a grain of salt. I mean, for me, genuine interest in work and genuine interest in being part of a team are hugely important to me. That's what I look for in an application. So people who are able to highlight some work experience that somebody's had or the work effort they put forth in a letter is important, and how that applicant has interacted on the team at the institution. So, for writing a letter, I think if you can highlight how that applicant got along with everybody in the institution, that's important.
I think one of the other things is, I have to admit, I don't really like the ranking system of applicants, because the thing is this is just my perspective, and again, take it with a grain of salt, is like, how many number ones are you going to give out? But then if you rank somebody 5 to 10, is that a red flag? Is 2 to 5 potentially a red flag? And so I don't know how much it really helps. I don't know. What's your perspective on ranking applicants?
I'm not a super big fan of it. I think that immediately biases the letter reader as to what your thought process is there. The problem is, what do those numbers mean to any writer? It could be totally different. So I would consider ourselves to be, fortunately a top program. We typically match in our top 10, 12 applicants every year. So if I write that somebody's a 2 to 5, that's a pretty awesome applicant, right? because I would be thrilled to get that person in my program. If I write 5 to 10, that means that I probably don't want them to necessarily match at my program. I'd be okay with that. But if you're in a small program, say in the Midwest, and you're used to having to go lower on your rank list, a 15 might be somebody you're still super thrilled to get. Because it's harder to recruit applicants to smaller programs in a less geographically sought after location. So those numbers mean different things to different people, but I don't know what they mean to the person writing the letter.
Yeah.
So I think that it biases you in an unfair way. I kind of wish they would just get rid of it, but I don't really control that.
Yeah, so that's why letters of rec and then obviously away rotations. So if you're someone who's going on an away rotation and you were able to be seen in action by someone, obviously that's subjective, but more of a realistic thing that someone can base their judgment off of.
Right.
What are some things you look for in a sub-I who's rotating?
Yeah, good question. I think that visiting sub-Is are different than home sub-Is. A home sub-I we may already know a little bit, and so they may hit the ground running a little bit harder. Consistency is important for me for a home sub-I, of somebody who really sort of like gets along with everybody.
Yeah, like what you have.
It's not treating me as a faculty member different than the intern, than the chief resident or something like that. That type of behavior is witnessed and is an immediate, you're not matching here. Because I think some students don't really realize that we talk about people, and that type of behavior is to be avoided. For a visiting sub-I, I think somebody who is able to come in and learn a system very quickly, integrate easily without being obtrusive or having to ask for every little thing, tells me that there's somebody who is proactive and who can integrate into a team quickly. And I think that's a great trait. I like students that help without being asked, but help in a way that isn't obtrusive. So, got a great student right now who pretty quiet, but she hands me instruments in the operating room before I even knew that I wanted it. But doesn't shove it in my face. It's somebody who's just kind of holding it, waiting, and I look over and I'm like, that is what I want.
That's amazing.
So that's somebody who shows intuition in an operating room, but isn't invasive about showing it to me. Those are great skills. Those are not necessarily something you're taught. You just understand the environment.
Yeah, it's so true. Some of those skills are just innate, and even just the importance of just being pleasant and people wanting to be around you, because it's such a long training pathway.
And it's different than like internal medicine, where someone who you're interviewing, you might be with them for a month or two in their whole residency because of your specific specialty. For this, you're going to be working late hours, early mornings, really close with this person. So it's someone that you
8-hour
would
cases,
like to be around. Yeah.
In addition to that, we could talk forever and ever on this, but there are two other points that I want to hit about the application. As you mentioned, fortunately or unfortunately, USMLE Step 1 is pass-fail. USMLE Step 2 is now assigned a score, which is making, I feel like, the number of publications that applicants have go higher and higher and higher each application season. So what is kind of your thought on research and having it in terms of competitiveness? Do you suggest taking a year off, or can you still apply without doing that and still be productive?
I would say this is the most common question that students at Penn sit down to meet with me about, is asking my advice on whether to take a year out. I don't think there's a right answer. I think the best reason to take a year out is because you want to take a year out. Right? So if you feel like you need a break from academics, you feel like you just want to work for a year, that's a great reason to take a year out, and I would encourage anyone to do that. I think the next best reason to take a year out would be somebody who has decided late that they want to do plastic surgery and has not had an opportunity to develop a story, right? Or has not had the opportunity to get to know people so that when they apply, they have strong letter writers, right? So a research year is an opportunity to develop relationships. It's not necessarily about getting 80 publications, because, for a lot of people, their research is not done before their application even goes in. And so the outcome of that year doesn't show up in a number of publications. What shows up is the relationships they've built, the talks that they've given, the letters that they get. So if you don't feel like you have relationships to be able to support your application, that's a good reason to take a year.
That's good.
Yeah, and the mentorship and getting those letters of rec potentially. I have had very strong mentees who have not taken a year off and have been productive, but like you said, established their interest in plastic surgery early on and did great in the match. So I don't think it's 100% necessary, but the points that you brought up were very important. The other scenario I want to kind of play out is I'm an applicant, all my friends are celebrating, and I just found out that I didn't match. And unfortunately, there's a stigma against the people who don't match. And I've gotten a few phone calls this year about applicants who haven't matched and trying to reason as to potentially why. Like, I'm calling you, what is the first thing you say that I should be doing and what to do next? Research year, general surgery, and then how to strengthen my application.
So I think part of it is trying to figure out why you think you didn't match. That, sometimes you can get some help from your medical school to look into that, of why they think you didn't match. Sometimes it's people thought they were more competitive than they were and they didn't apply to enough programs. Sometimes it's they were.
Do you have a number of programs you think people should apply to? It's probably applicant dependent. It's probably applicant dependent.
The honest truth, I hate to even say this because it's just an expression of the sad truth of the specialty and how competitive it is. I don't see a downside for everyone applying to every program.
Yeah.
That doesn't mean you go on every interview. If you're given interviews, you really don't think, if you're someone who's starting to get a lot of interviews, you should trim that down and not go on every interview, because you're just taking away an opportunity for somebody else at a program that you're not likely to go to.
Yeah.
So I think applying broadly makes sense. Trimming down how many interviews you go on is probably reasonable. So I think first off, talking to your mentors, talking to your medical school about why you think you didn't match. Is there a letter in that was not great?
That seems like a common theme.
I've definitely seen that. I've seen students not match because one letter is not up to par. Did you not match because you didn't demonstrate a story? You didn't demonstrate a prolonged commitment to the specialty? That's when maybe doing a year out, makes sense to kind of like build some new relationships and or bulk up your CV. If you can't really beyond that figure it out, then it's about trying to figure out, do I still really want to do this specialty? Do I want to try to move in two directions simultaneously? And that's where you get into like, all right, am I going to go into it general surgery and potentially do an independent training pathway down the road? But at least I'm moving forward. Right? Moving forward is always important. If you didn't match and you already did a research year, doing another research year makes no sense because you're not doing anything new.
Yeah.
So those students, I tend to encourage them to probably just keep moving forward.
Yeah.
And maybe
demonstrate clinical success.
Correct.
Yeah. And I think to your point about the letters of rec, I mean, one student did this to me recently, which I think was great, is ask me, can you write a strong letter? And I think to the, not only, as you mentioned, there we have a wide range of listeners. So I think to the people writing letters, if you don't think you can write a strong letter, or you may potentially your letter will hurt, it might be worth being honest to an applicant, because that may potentially hurt them in their application. But anyways, anything you wanted to add?
No, I completely agree.
Yeah. So
the only thing I also wanted to bring up, I think it's a good time for a plug for just the Penn Residency program, since we have a lot of listeners and a lot of applicants who will be listening. If you want to just speak on our program and why you're proud of it, and what we're all about here.
You trained here and now you're part of it.
I trained here, I stayed here, I stayed for a reason. I like the culture. There are a number of things that I think make our program great. There are a number of great training programs out there, so I don't want to
of course.
Make it sound like we're better than anyone else. I mean, there's a lot of great training programs in the United States. I think we're one of them. I think we are that way for a couple of reasons. One is we are an institution that still focuses on teaching surgery. We are a high-volume surgical center that runs basically the full gamut of plastic surgery. We've got some tremendous resources with Children's Hospital, which is like no other children's hospital on the planet, great adult hospitals. We've also been able to maintain relationships with people in private practice to help teach cosmetic surgery, because some centers don't really have a lot of cosmetic surgery in them. And so I think that's part of our specialty, whether you like it or not. I think we need to teach it. So, I think from a pure surgical perspective, we do a great job here. But we also just have a great group of individuals, a culture of inclusivity and diversity of people's backgrounds and what we bring to the table. But what isn't diverse is our faculty get along. That translates into breeding a culture of residents that get along. And if you enjoy where you're working for 6 years, come out of the end of that training a better surgeon.
You're probably going to guess what I'm thinking, but signaling.
Oh, yeah.
I feel like every person asks me about signaling, and any way that signaling actually helps an applicant, do you think?
I have mixed feelings about the signaling process. I think that many people who really wanted to come to our program found a way to do a sub-I here.
Yeah, that's how I feel.
It was already a signal. Now, those people don't signal us because they're not allowed to, I think, by the way the signaling program works. But so there are some people out there that wanted to come here as a sub-I, couldn't get a rotation because it's competitive, but they have a particular reason to wanting to come here, like a family member, or they grew up in the area or something like that. I think that's a good reason for a signal, but then you also need to explain the signal, which there's that blip about why you're signaling. I think it needs to be a real reason, not like
a generic,
not
whatever.
Your program's great, I've heard a great reputation, I wasn't fortunate to be able to rotate there, but everyone says it's awesome. That's not a great use of a signal. In fact, I would say that probably hurts you.
Yeah, that's kind of my sense.
How many signals is it now?
20.
I think it was like 5.
It was 5 for a while, and I think 20 is too many. I think it defeats the purpose. I honestly think with that many signals, it probably won't really mean all that much.
And it also works the other way. It's like if you don't signal a place, it's almost like...
Correct.
Which is the issue, because we were just talking about how competitive the specialty is, and we advise that you apply everywhere, but then you can only signal.
No, that's a good point. So what are your thoughts overall about the independent track and perhaps the differences in trainees and then the future of it?
This is a controversial topic. If you go to national meetings like ACAPS, and we talk about this, you will hear some very different opinions about this national. Obviously, I trained that way. I was very thankful for the opportunity to be able to become a plastic surgeon.
Me too,
after doing general surgery. I do think some things have changed since you and I went through training, particularly me. I mean, when I went through training, there were 2 training routes. There was like the combined route where basically a plastic surgery resident came in, they did 3 years of 3 years of general surgery and then 3 years of plastics. And that was met with an independent who did 5 or 7 years of general surgery and then 3 years of plastic. So the only difference between those resident cohorts were the number of general surgery years they started with. So those residents integrated really well. And you might even argue that the independent resident had more surgical experience and was more surgically capable. That transition, when nationally we went to an integrated model and a 6-year training program right out of medical school, most of those programs, including our own, have trimmed the number of general surgery rotations you do in your 3 junior years and replaced it with plastic surgery rotations, which means now you're really doing 5 or 6 years of plastic surgery, which means that integrating if you're running 2 programs, having an independent trainee try to join an integrated program, those integrated 4s have already been doing plastic surgery for 3 years. The independent resident coming in is way behind. Mm-hmm. And it is very difficult to run those 2 programs simultaneously. Mm-hmm. Personally, I also think general surgery training in the United States has changed. Mm-hmm. Some might say deteriorated from 10, 20 years ago when I went through that. I think the changing medical legal atmosphere in the United States means residents are doing less independent operating, they have a lot more hand-holding and oversight. They're not as adept surgically coming out of training as they used to be, which means that their skill set is not what it used to be. Mm-hmm. Which means you're now trying to train somebody how to be a plastic surgeon in 3 years, including breaking some bad habits. And that translates into an integrated, independent training program having some real major obstacles that it didn't used to have. Mm-hmm. So, it's no secret we're not filling our independent program anymore. We have expanded our integrated program. For me, it was about trying to run one consistent program with a consistent output. I think a program can still do that in an independent model, but doing both models simultaneously has become increasingly challenging. Where does that mean training will be 10, 15 years from now? I don't know. Leaving a general surgery program and matching into an integrated program that most people don't do, but those options do exist out there if there are slots open. So, there are a lot of different ways of getting from point A to point B. I don't know where the independent training pathway is going to go. I'd still like to think that somebody will train those.
Yeah.
Will it be us? I don't know.
Yeah, and it's a good option, like we said, for those people who are either latecomers, want to be a little bit more clinical to start. They will still find a path to plastic surgery, perhaps unmatched.
Yeah. You have someone who doesn't get exposure to plastic surgery who's now expected to know early enough to apply that, versus in the past when it was, I know I want to do surgery, and then you find your way into plastic surgery. But as we learn more, new techniques come out, we expand plastic surgery, it gets increasingly hard to fit that all into 3 years. It's almost impossible.
And similarly, general surgery is like a lot of it's minimally invasive,
which doesn't translate as much as
or
it used to.
endovascular or whatever.
It doesn't really translate at all into open surgical techniques. So it's a challenging landscape out there from that aspect of things. I don't know where it'll be 10 or 15 years from now.
Yeah, this is another kind of difficult question that sometimes I luckily didn't have to go through, but I'm curious about what your thoughts are, is like the applicant who co-applies, who because they're concerned that they're not going to match into plastic surgery, and so then they apply to general surgery. Any tips or tricks? Because me, having trained in general surgery, I think to myself, like, if I'm a general surgeon and I'm reading an application from somebody who clearly wants to do plastic surgery, am I super excited about matching them as a categorical into my general surgery program? Any thoughts on that?
I don't know how you navigate that. I think that you can really hurt yourself on both aspects of things. I think if there's a way to not apply to the same institution in two different programs, that's probably a good idea.
Yeah.
Because if that institution knows you're applying for both, you're in a difficult spot. I don't know what the right strategy is.
It's a tough position.
I actually think maybe applying in both is not something I would encourage most applicants to do.
Yeah.
You just lay your cards down, you go with it, you match or you don't. If you don't, try something different the following year.
Yeah.
Hedging your bets is, I think, trying to game a system that doesn't get gamed easily.
Yeah, that's definitely true. So now talking a little bit about residency, because residents probably are listening too. What separates a good intern from an excellent intern in your eyes?
Yeah, organization is huge. I mean, I think that one of the number one tasks of an intern is just being organized and helping to run a chaotic system. Senior residents are running all over the place. Attendings are sometimes available, sometimes not. It's the interns' responsibility to stay organized and make sure the little details are followed up on. So, being detail oriented and organized, I think is a great skill set.
I wish you could have listened to this podcast.
I know, if only it was here a year ago.
Being available, all the time is great. I think learning how to do that well is a challenge for some people. You're not necessarily used to that as a medical student. People calling you left and right, expecting to have immediate answers. You got to be available. I think that having an emotional intelligence of recognizing that there are a lot of people in the institution that you need to get along with is not necessarily something that you can easily train for, but is a skill set that if you have it is super helpful as an intern, because you got to interact with nurses, staff, physicians, senior residents. There's just a lot of people you're interacting with, and you need to be able to get along with them. That's it.
Yeah. Thinking back to residency, and what I perhaps struggled with a lot is saying yes maybe too much and trying to balance clinical work with research and everything else. Is what advice do you have to give trainees about, struggling to kind of balance it all? What I try to advise people is clinical success should be your focus.
I totally agree. I mean, I think, like we have a research requirement here, but it's very minimal for the first couple of years. And I stress when I meet with my interns early in their residency that first couple of years I think is really about getting core surgical skills and knowledge base down. So focus on the clinical aspect of care. Focus on taking good care of patients and reading in every opportunity that you have. Mm-hmm. Research, on the grand scheme of things, is completely unimportant as an intern. Mm-hmm. So I just tell people to kind of ignore that aspect of things for a while.
Yeah, it's funny. I remember as a medical student, a neurosurgeon, pediatric neurosurgeon, the same guy who wrote my letter, told me the more you get into an OR once you start residency, the better. Like every time you get into the OR, you will learn something. If it's from learning how to scrub your hands better, learning how to gown and drape or whatever, like every time you go in. And so what was something I offer to, like, as advice to people is like, try to get as much OR experience as possible. As you get older, people are going to be expecting more and more of you. And so when you start, that's the time to, get your feet wet.
Yeah, I would agree with that. I think it's great advice. I think that some interns, have a hard time balancing that, like, I need to protect my own time to become a surgeon versus I need to be the nice guy who helps out on the floor and helps the nurses.
Yeah.
It's a difficult balance to walk.
It is.
Or a difficult line to walk. I think that finding that balance is different for everybody, but you do need to protect your learning experience of getting into the operating room.
Yeah. And it's also different on each rotation. Some rotations are set up to be more, you're able to get to the OR a little bit more, and some are set up for, and you just have to frame it in a way where you learn either way. Okay, this rotation I'm like really learning how to manage sick patients on the floor or something, and then next month I'm gonna be able to get in the OR a little bit more, and you kind of just have to, especially when you're off service and stuff, there's things you can't control as much.
Yeah. And there's probably ways that you can navigate and still be nice to the APPs or NPs who are helping on the floor, and you get into the OR. I think it's important.
So you can go to the OR, but make sure you check in frequently with the APPs on the floor. You can go to the OR and make sure your phone is being answered, right? You can't go to the OR and then just disappear and hope that everything happens. Like that's where problems arise.
Yeah. Sure. How about burnout? So any advice on preventing burnout?
Yeah, I think most important thing is finding time outside of the hospital to do your best to have meaningful and effective me time. Whatever you like to do. You may not be an athlete, you may play music, do art, dance, whatever. I don't really care what you do, but finding some time to rejuvenate yourself by pursuing your hobbies is important. Intern year, all of residency, there are times that are very stressful, but the reality is that doesn't end at residency.
You're so right.
Being an attending is actually, contrary to what some residents believe, being an attending is actually more stressful. There's a lot more responsibility. If you don't learn early to balance your life and maintain healthy, endeavors outside of medicine, those bad habits are going to turn into even worse habits when you're an attending, in my opinion.
No, I couldn't agree with you more. I've spoken to you within the past month probably on a really bad day of mine, and I think learning how to cope with your bad days, even as a trainee, will give you some leeway as an attending when you're trying to deal with it.
Yeah.
Because it's not fun and it doesn't go away.
It doesn't go away.
Anything you wish you had known looking back? I think for me, like I said, I think my one regret is I probably would have gotten into the OR a lot more as a 1, 2, 3. Anything looking back that you regret as a trainee?
I definitely try to live my life without regret. I think that, everyone can look back and say, I would do this differently, but, would I have, in an ideal world, would I have prolonged my training as long as I did and become, I think I became an attending when I was 37.
And now you're 38.
Now I'm 38.
You're ageless. Can I just say that off script? You are ageless.
Not true.
Somebody said that the other day.
In an ideal world, would I have loved to have shortened that training period and been more decisive about my career choice? Sure. Do I regret it? No, because I'm the surgeon I am today and the person I am today because of my experiences that got me from point A to point B. So I don't think you can live your life with regret, and I will leave it at that.
Yeah.
And one more point about getting in the OR as much as you can. It's funny. It's the same thing in sports. Like, if someone was, when you're like playing basketball or whatever growing up, everyone's like, well, what can I do to train to get there? Like, just play as much 5-on-5 basketball as you can. And that's step one, because all the little nuances and things you pick up are just from being there and stuff. The little like mistakes you do, you can only learn from going through the motion for a lot of these things in the OR. It's not like you could read a textbook and then, I should have prescribed this instead of this. It's more like it's very difficult to teach other than going through the motion.
It's so true.
Yeah.
There's so many things that I've done where I've like tried to read, tried to prepare, and it definitely helps. But I think until you actually do it, I think that's where your learning curve like really, heads off. But when you're offering advice to trainees who are considering academic versus private practice, or what specialty to choose, do you have any advice on either one of those, like academic versus private, or what specialty to choose?
Fellowships,
I think the decision to do a fellowship does dovetail into where you want to practice and what the environment is you want to practice. Like, if you kind of like microsurgery, but all you really want to do is some breast micro, and you're going to work in a less competitive environment, you may not need to do a fellowship coming out of like our training programs. We do a lot of micro to begin with. If your goal is to work in a big academic tower in a busy metropolitan center, you may need to do a fellowship to make yourself have some more nuanced skills and make yourself more hireable. If you want to kind of steer your career in a particular direction, whether it's hand, craniofacial, or whatever, I think fellowships are important. Private practice, group practice, academic medicine, I do encourage people to be open-minded to all of it, because you can turn some of those into different blends or hybrids in a lot of different ways. Like, I'm an academic surgeon. I don't do a lot of research. I don't really publish a lot, and I don't honestly even go around the globe giving a lot of talks. It's just not something that like is part of my academic career. Does that mean I should have chosen private practice? No, because I like being around trainees. I like being around the colleagues that I'm around. I like having a lot of partners. I like doing complex surgery. If you're going in a solo practice, I do think you need to be someone who doesn't mind being alone.
Yeah.
It can be very lonely out there when you're in your practice on your own.
Yeah.
And I don't think some trainees completely understand that. They look at it as having a lot of self-control, or having control over their own environment, or being able to build a business. And that may be great on many fronts, but I do encourage residents to try to really take a good hard look at who they are as a person and see whether those environments make sense for them.
Yeah. No, that's great advice. What do you think? Should we hit the final?
Yeah. Let's do that.
If you could distill everything we just talked about to offering a few words of advice to medical students and residents, what would you say?
I don't know. That's so hard. I think that if you've gotten to the point where you're really seriously considering plastic surgery, you've already probably made the most difficult step, which is just committing to what you want to do. Beyond that, it's trying to set yourself up for success in achieving that goal. And again, I'll get back to what we talked about earlier. I think developing a story, rounding out your application, and being yourself. Please be yourself when you go on an interview.
Yeah.
It'll matter in so many different ways that you don't realize. Number one, you'll give off a better interview if you're just relaxed and you are who you are. Worst case scenario, you are who you are and they don't like you. You probably shouldn't be at that program anyway.
Yeah,
because
so
you're
right.
not going to get along with the people who are there. Be yourself so that when somebody finds you and likes that person, you get along with that family when you arrive as a resident. And I think that's my last
it's such a good, there's been some times where I've interviewed somebody and I've said to myself, like, this person's either this person I know really well, or this person was a sub-I with me and they were unbelievable, but on interview day something happened and they were a completely different person. And to your point, just being yourself, I think is the best. And if I could break the interview and say, just go back and be yourself, I think that would have been better. You want to ask the final two?
Yeah. So we ask this to every guest on the podcast. What's your favorite surgical instrument? And I'll tell you after your answer what we hear the most.
Is it the Freer?
Wait, don't give them hints.
I'll probably say something I would be surprised if anyone said it. This is different. It's not a true surgical instrument.
Okay.
But the Insorb stapler.
Really?
Yes.
That's the first
one.
Probably added years to my
Yes, I agree.
Yeah. That's the first.
I do a decent amount of abdominal donor site closure, body contouring, breast reduction surgery. That instrument has revolutionized the pace at which I can close a wound and re-energized me in terms of how much work I can actually do in a calendar year.
Yeah.
And can I say, if you use it correctly, I honestly think that the outcomes are the same and can be better.
That's what I was going to ask.
How it everts the skin
because
edge.
Because as a obviously as a junior resident, even I don't see a lot of them in follow-up or in clinic. So I'm just curious the difference.
Yeah, you definitely pick some of those staples out. They can erode through the skin, but you know what? Standard, deep
I have stitches erode through the skin.
With monochrome, I pick those out of wounds all day long also. I think, student or residents don't really see that, if you don't really spend a lot of time in office hours, all wounds struggle, have the potential to struggle. And so, Insorb staples are more difficult to get out when they erode out, but when used properly, it can really yield a great looking scar and takes, a tenth of the time to do.
Yeah. Really everts it, makes it easier to run after too.
Yeah.
Sets it all up nicely. The one that we hear the most, just because I want to tell you, is the McCabe dissector.
Yeah, I like it. But interestingly, when I started doing free flaps, I did most dissection with tenotomy scissors, not a McCabe. I've only switched to a McCabe because I've seen so many other people using it, and I'm like, all right, I'll try it. It's okay.
I like it.
I use it.
Yeah.
I use it, but I still, to do dissection of difficult vessels, I use a variety of McCabe, tenotomy scissors, and a Freer elevator. So for that reason,
it's not your favorite.
Neither one of those is hands down my favorite.
That makes sense. Our last question is, and I already know the answer, and so do you.
I think I know the answer.
Yeah, same. What type of music do you like to listen to in the OR?
So I started. There's the obvious answer that people who know me well know that they think this is the only form of music that I listen to, which is very untrue. I listen to a lot of music.
Just say it. What station do you listen to?
Yacht rock radio. Yes.
It's a good station.
It's a crowd pleaser. It puts you in a good mood.
I agree.
Most people
and it puts most people in a good mood.
Yeah.
It's it's easy to listen to. It's songs that most people are familiar with, and it's not invasive. So I just like it, and I could probably listen to that on my own.
It's a good go-to.
I love it.
Yeah, because that's a good distinction as well. It's not always what your favorite music is. It's what is going to get the most people through the day.
It gets everyone in a productive mood.
Yeah.
But it's nice too because it's not so upbeat where if the case needs a little bit more attention, you feel like you're getting distracted. It's perfect. I totally agree.
Yeah, that's been awesome.
I got it from you. I got it from you. And I actually listened to it during fellowship, and I'll tell everybody else because of you. Well, this was awesome. Our first education series with a program director, so this is great. So
amazing. Thank you so much
for getting me on. I know.
Yeah, this is fun.
It was a little overdue.
Yeah,
but I'm glad we were able to do this.
Yeah, this was great.
Me too.
It's been a lot of fun.
And it's going to be super valuable to our listeners. So we really appreciate it.
Awesome. Perfect timing.
Yeah. Thank you.
Thank you for listening to The DIEP End, a plastic surgery podcast. If you've enjoyed today's conversation, please like, subscribe, and leave a rating on Apple Music or Spotify. Video from the podcast is available on Instagram and YouTube at The DIEP End Podcast. Join us again soon for more conversations with luminaries and experts in the world of surgery.